So I'm going to talk about surgical treatment of dystonia, which basically translates to deep brain stimulation for dystonia. This really is my passion. I've got a policy in my practice, never say no to DBS. So we do a lot of DBS, and it's very rewarding because patients, it's just fun to see how well the patients do afterwards. I had a patient who came in from Hawaii for his DBS surgery for Parkinson's just a couple of weeks ago. And he comes in to follow up, his tremor's gone, and he's like, this is kind of crazy. And I'm like, I know exactly what you mean. I talk about that with my wife all the time. That we're actually, people are signing up to have these things implanted. Battery under their skin, you can feel the hardware, and 2 holes in their head and wires going down. And people would not be signing up for this unless the condition that they had was serious and that the safety and efficacy of the treatment were positive. So this is brain surgery for quality of life. It is not malpractice, I always say, for a neurologist not to send a patient to a neurosurgeon. So if you have Parkinson's or dystonia, you can go your entire life without even thinking about seeing a neurosurgeon. So the bar is set pretty high as a result when considering to do brain surgery for your condition, whether it be dystonia or Parkinson's or essential tremor. The goal is to restore function. So people have lost function due to their condition, and we restore function with this so-called brain pacemaker. We always ask patients in follow-up 3 months, 6 months, is your life better? Would you do it again? And well over 95% say yes. So I'm going to talk about a historical perspective, how we got to where we are today implanting these brain pacemakers, what the indications are with focus on dystonia, and then how is it done, what the surgical procedure looks like. So when did you first learn about DBS? This is a question I ask my patients. The answers vary. Some people say, I've had this disease for 10 years and I just found out about it 3 months ago. It's not an experimental surgery. This is not experimental. It's not a treatment of last resort. You don't wait until everything else has failed before you try to salvage your situation with this neurosurgical implant. Over 150,000 patients have been treated now, and it is covered by insurance. So neurosurgical procedures for movement disorders started way back in the early 1900s. And at the time, they're primitive. People would have a serious tremor, and a surgeon would actually go in and cut up the spinal cord, and that would alleviate the tremor, but people would also lose voluntary movement. They'd become weaker or they'd become paralyzed. And as neurosurgery evolved in the 1950s, they found that if you accidentally take a blood vessel in the brain on somebody with tremor, they might wake up and their tremor will be gone and they can still move their arm. So that's when the next iteration of neurosurgical treatment for movement disorders developed. It turned out that artery that they would take did not have a consistent distribution of brain that would feed, meaning that in some patients you take it and the tremor would go away and they'd be able to move. Others, you take that same blood vessel, the tremor would go away, but they'd be paralyzed. So it's less predictable results. When you destroy a part of the brain, you can't reverse that. And if you destroy the wrong part of the brain, that's a permanent deficit. So that became an issue, but during the 1950s, the techniques and strategies for this targeted destruction of the brain to treat tremor, to treat Parkinson's, evolved. And this is an MRI of the brain right here. Right? There's the eyeballs there, this is the nose, and right here, that little ring right there, that's the stroke, that's the lesion right in the middle of the brain, in the thalamus, that's used to treat a tremor. So in the 1960s, late 1960s, a drug, levodopa, was introduced, and this was the miracle drug for Parkinson's. And it remains today the cornerstone of medical therapy for Parkinson's disease. And this really changed the world of Parkinson's. So for about 10 years, people stopped doing movement disorder surgery, these brain surgeries for movement disorders. Because of the complications of medical therapy that became apparent in the 1970s, in the 1980s, there was a renewed interest in using neurosurgery to treat movement disorders in those patients who were developing these side effects from medication. However, creating a stroke, destroying the brain, while it can be done safely in certain situations, it turns out if you do the same thing on 2 sides of the brain, you start seeing a new constellation of side effects and complications that you don't see when you do the same lesion on only 1 side of the brain. So that was a limitation, not being able to treat 2 sides of the brain in the same patient, not being able to treat the left arm and the right arm, only being able to treat one. And it turned out, as the safety of this procedure evolved, one thing that they would do is they would use electrical stimulation while they're kind of surveying the brain and seeing where they want to make that lesion, they'd use electricity, and electricity would have the same effect of the lesion. So you'd see the tremor stop, and you'd also be able to assess for side effects. So they used that observation that you could get the same effect of the destructive lesion with electrical stimulation to, in effect, develop a brain pacemaker, adopt the technology of cardiac pacemaker. You see this is the first cardiac pacemaker here, to make a brain pacemaker. And that is what allowed surgeons to treat both sides of the body in patients with movement disorders. So there's a contemporary heart pacemaker, and there is the brain pacemaker. So you can see the similarities with the generator, the source of the power, the electrodes would go in the heart or the brain. So since that time, the first neurosurgical DBS procedure was done in 1991 in Oregon. There's been a lot of experience and better understanding of what the safety profile is, the efficacy. It's a safe procedure. It's not without risk, but it is safe. It's non-destructive, which means that we're modulating the brain. We're correcting the abnormal brain rhythms with electrical stimulation, much like how you'd correct an abnormal heart rhythm with a heart pacemaker. So it's non-destructive, it's reversible. So say, for example, God willing, a cure comes down the road for one of these conditions, you can take this out or you can turn it off, and the brain is still in its same intact structure as it was before the operation. And it's adjustable. If you have a good year, 5 years, and then things start coming back, the neurologist can kind of tweak the system to improve the effect. So to focus on deep brain stimulation for dystonia, the vast majority of what I do is for Parkinson's, next is essential tremor, and then next is dystonia. So there's different types of dystonia. Generalized dystonia, which is most or all of the body. Focal dystonia, which is localized to a specific part of the body. Multifocal dystonia, so it's 2 or more unrelated body parts. Segmental dystonia, 2 or more adjacent parts of the body. And hemidystonia, where the arm and leg on the same side of the body are affected. So in 1997, the FDA approved deep brain stimulation for essential tremor. In 2002, they approved it for Parkinson's disease. And in 2003, the FDA approved deep brain stimulation for dystonia. And they did this through the Humanitarian Device Exemption Program, which is a program that the FDA has that allows, that permits the use of therapies for diseases that are considered orphan diseases, which means that there are too few patients with the condition that might receive benefit from this therapy to be able to conduct a phase 3 trial to demonstrate efficacy of the therapy. So some criteria for patients to undergo DBS for dystonia. It's primary dystonia. That means it's spontaneous. It can be from genetics, but it can't be the result of injury. So patients have to be tested for Wilson's disease, which is basically like there's a metallic toxin essentially in the brain. Levodopa trial to see if they're what their dystonia responds to. It also helps levodopa is a medication for Parkinson's disease. We screen patients by getting an MRI of the brain to make sure there are no structural abnormalities in the brain. If somebody's had, for example, cerebral palsy, they may have dystonia, but that dystonia is connected to that abnormality in the brain, the lack of oxygen and the injury that took place. And these are not great candidates for deep brain stimulation. Torticollis is part of the primary dystonia category. It's not approved for focal or secondary dystonias. So that's an important criteria. If you have a genetic mutation that was discussed in the last talk, for example, DYT1 mutation, those people do great with deep brain stimulation. It's a home run. If there's an abnormal MRI and there's a history of cerebral palsy or some other injury that preceded the development of dystonia, those outcomes are less predictable. Now, we have a consensus group that looks at each patient when we decide whether to proceed with DBS. And there are such situations where we say, look, this person is debilitated, they've tried everything, nothing's working. In that setting, then the committee may say, yeah, let's proceed with considering deep brain stimulation. But in that case, it is being used as a treatment of last resort, and we counsel the families that the outcomes are much less predictable, what we can expect. And oftentimes the insurance won't cover it. The best results we've seen are in children and adolescents with DYT1 mutations. There are adults with primary dystonias. Oftentimes these dystonias result in structural deformities in the spine, like scoliosis. So the less time the body is kind of adapted permanently to the dystonia, the better outcomes we get. So subtypes of secondary dystonia that may respond, intact basal ganglia. That's the structure deep within the brain that we're modulating. It's part of the circuitry. So if that's normal, somebody with secondary dystonia may have a response. This is possible. And there's some other examples, tardive dystonia, anoxic brain injury, where there are reports just showing that patients do well with the surgery, but not as well as primary dystonia. So this is an example. Let's see. Okay, so this is actually somebody who loaded this. This is the patient's video that he loaded up on YouTube. This is an example of an adult with primary dystonia, and you can see sort of what dystonia is all about in this gentleman, and how thin he is because the muscles are always being contracted. So a real disabling disease. And this is a primary case. So the patient undergoes deep brain stimulation with dramatic results, and you can see he's already put on some weight. And really life-changing, and he put this up on YouTube. He talks about, his employment, his family, like he really got his life back after the operation. And this is not one of my patients, but it's the video I've been showing, and I guess at some point I'll start showing my own patients. But he did. This is a fun video. So deep brain stimulation. There is class 1 evidence for efficacy, meaning that, in terms of the type of studies that are conducted, that are published, and this is in the New England Journal of Medicine, which is the top medical journal in medicine, looking at where patients underwent surgery and either went with or without stimulation. So you can actually leave the generator off, and they compared how patients did with and without the stimulation, and this is up to 9 months. Basically, that evidence really showed a dramatic improvement in patients who had undergone the surgery compared to patients who did not. And this slide basically shows that the people with those skeletal deformities like scoliosis, they basically did a lot better if they had the dystonia for less period of time. So the longer you go without this kind of a treatment, and the more your body adapts, the less dramatic the result is going to be, because you already have these fixed deformities in your spine and in your body. And again, this just shows improvement in the dystonia scores compared to disease duration. So the less time with the disease, the better improvement in the dystonia score after surgery. And this again just shows more data showing in 30 consecutive patients the efficacy of dystonia. And this is from Ron Alterman's group out in New York. And I think he might be in Boston now, but they've really been some of the leaders in doing DBS for dystonia. So I'm a surgeon. The keys to success with DBS is, first and foremost, good patient selection. This, for example, if somebody has secondary dystonia, that kind of sifting through the symptoms, the medical history and everything, the patient selection is initiated by the neurologist. So a neurologist has a lot of tricks up their sleeve, a lot of arrows in their backpack, whatever. So they can use Botox, they can use medication, and DBS is just another tool in their armamentarium that they may decide to draw upon in order to optimize management of a patient. So they're the ones who kind of select the patient. We'll often meet in a consensus, or depending upon kind of the environment, decide, all right, let's proceed with surgery. I kind of talk about the risks, the benefits, and oftentimes I lean upon the neurologist, particularly in the setting of dystonia, to kind of assess what the likely benefits are going to be with that condition. So once a patient's been selected by a neurologist to proceed and is safe enough for surgery in the eyes of the surgeon, then the next step is placing the leads, so making sure the leads are placed well and safely. And then afterwards, the ball is back in the court of the neurologist doing programming the pacemaker. So I talked about this earlier, another disease that is approved through the Humanitarian Device Exemption Program is obsessive compulsive disorder, and then epilepsy we're anticipating will be approved sometime in the next year. There have been small studies looking at all these conditions. I was part of a clinical trial where we, all together, we did 42 patients with Alzheimer's disease and put deep brain stimulators in. And I did 13 of those patients, and that was a lot of fun. But these are the only ones that are really kind of, have some kind of labeling by the FDA. So how's the procedure done? Again, the goals are to do it safely, get you in, get you out, get you back home, and to hit the right target. So some things that have evolved since this procedure first developed in the 1980s is we have improved imaging. So we have the ability to really see the structure, the fine structures within the brain at the resolution of, I mean, I'll move my cursor like 0.25 millimeters, and I'm like, I want to go back. I want to go back to where I was before. So that's the GPI. That's a structure we use for dystonia, and that comes out. That really pops out in this this specific sequence. This sequence was done at the University of Florida specifically to optimize the imaging and resolution of a DBS structure, the GPI. And we use our ability to see these structures along with the mountains of data that have come through from decades of this operation, where this is a study that came out of UCSF showing kind of the sweet spot within that structure where they got the best results with dystonia. To basically say, all right, I want to hit that same structure that I can see on the MRI now. And then in surgery, this is what the surgical procedure looks like. We have the stereotactic frame that we put on, and basically that thing that the head is in, that's how we're able to hit a target within 1 or 2 millimeter error, about 8 centimeters deep through a hole about the size of a dime right behind the hairline. And the CT scan is what we use to be able to both register the system, but we also use it to actually make sure at the time of surgery that I hit the target that I said I want to hit. So we combine MRI with the portable CT scanner, which is why we were able to do this asleep. And asleep DBS turns out for dystonia to be fine. With Parkinson's, the labeling actually implies that the patient should be awake, but because of the challenges specific to dystonia, the surgery is often done asleep under general anesthesia regardless. So this is the frame. Again, this is how we hit a small target, throw a hole about the size of a dime, going in about 8 centimeters into the brain. And there it is again. And it's a little video showing that workflow, putting the frame on. So the bark is worse than the bite with these frames, but it's, this idea of being awake for surgery is what kept often may keep patients away from surgery, having them elect to proceed with medical therapy. There's a lot, who wants to go through brain surgery? I always think, at what point in your condition do you look in the mirror and say, all right, I'm going to go see the surgeon? But that's our serotonin, that's our smaller CT scanner that we use in the operating room to register and to verify that we hit the target. And that's the Lexcel frame. This thing's been around for over 50 years, the stereotactic frame. And that's basically, again, how we hit small targets accurately through small holes. Risk of bleeding exists with any neurosurgical procedure. So this is the planning station, how I plan my operations, basically making sure I avoid this blood vessel right here, get it to the brain and just kind of float down to the target. And this is during surgery. Again, patients traditionally have been awake, but everything I do now is asleep. And this is what the system looks like. There's examples in the back table of the generator, and this is the lead. This spans ½ an inch across those 4 electrodes, and those are what the neurologist will activate when they start programming. You saw that bald head earlier, but this is the haircut I do. Nose, eyes, forehead, ear. So this is behind the hairline, a little flap, and the hole would be right there. And then, at the time of surgery, we get this picture that shows where those 4 electrodes are, and making sure that we kind of hit that sweet spot that we're targeting. So the electrodes are placed, and then we do a second operation at the same time, where we put the battery goes in the chest, and then after that, programming with the neurologist. So I've treated over 500 patients now. We're doing everything asleep now. We've moved in that direction. There are risks with any procedure. Hardware failure, this is a circuit. So you don't want a short circuit, you don't want an open circuit. And we triple check these circuits at the time of surgery. Twice out of 510 patients now, we've had to take somebody back to replace one of these components because it broke and it wasn't working. Twice we've taken people back to surgery because the lead, where I put it, we decided afterwards that we were getting side effects or we weren't getting benefit, and we repositioned it. Infection, That's happened 3 times, and all those times we've had to take the whole system out. You can press the reset button, you can get all back in later. So those are all pretty low numbers, but I always tell people there's no guarantee against complication. It may happen to you. Cognitive, mood, verbal side effects can happen. I think that we see that a little bit more in Parkinson's than other conditions. And then hardware-related discomfort kind of comes with the territory. You're going to have a surgical implant underneath your skin. When does this not work? I think there's a handful of patients. I've got a patient coming down the pike that we're going to be switching our target from where we initially went to another target because we weren't getting the effects that we were expecting from DBS. So in conclusion, think of this as a pacemaker for the brain. It's not a treatment of last resort. It's very well established, long track record, and it's one of those things I often say, do you know anybody with DBS? And most people don't. And so we have an ambassador program. We have our nurse, Meg, who's a total asset. She's tremendous, and she's able to really connect candidates with people who've already gone through this whole experience. And it has a real demonstrated efficacy for primary dystonia. So thank you for your time and attention. Happy to answer any questions.
We've got some hands up.
Yeah.
Can you combine the operation for Parkinson's and dystonia at the same time for the DBS?
Yes. So a lot of Parkinson's patients have dystonic features. DBS works for those, like the toes clenching in. Mm-hmm. So DBS works for that. And in fact, the GPI, which is the target that we use for dystonia, is a target for Parkinson's. So about a little bit more than half of my Parkinson's patients have GPI electrodes. And I target the same way. So it's for dystonia with Parkinson's, it's the same target. Great, thank you.
Any other questions?
Oh, there's a question back here.
Yeah.
How does the lead you implant connect to the battery?
So there are, if you have both sides done, there are 4 incisions. One here, one behind the ear. That's where I connect the delicate brain wires to the heart ear neck wires. And then from here to here, where there's about a 5-centimeter incision where the pacemaker goes, we basically just pass a little rod underneath the skin, and then we pull up the wires. So we're able to connect the dots with what we call tunneling devices, which we use for many procedures in neurosurgery to pull the leads up. So from here to here, we're very fast, it's very adapted, connecting those dots.
And just one other thing, you mentioned follow. Do you have to work on both sides of the brain, or where does that come into play?
Yeah, typically it's bilateral. There's a lot of focal dystonias like torticollis where there's a sternocleidomastoid mastoid on one side may be pulling, and the neurologist may choose to have one side treated at a time. The surgery takes about maybe 20 minutes longer to do 2 sides compared to 1 side. So like for Parkinson's is a bilateral disease. So the majority of the time I treat both sides at once. But some people will say, you know what, I don't really notice it on my left, only my right, so we'll just do the contralateral side of the brain, the left side of the brain to treat the right side. So it's something that kind of is a decision made with the neurologist, the patient, and the surgeon. When you do one side, there's always a chance that we end up not getting the result and doing the other side. So there are some dystonias that are so unilateral, one-sided, that will start with one side.
Does that mean 2 leads then on both?
Just one wire on one side going down to the base of the battery. Yeah. Thanks again.